Assalamu alaikum. It's noon time. It's a great pleasure to be here, and I'm happy that the congenital is not ignored in the inaugural meeting of the Gulf Society for Cardiac Surgery. I'm going to discuss the ccTGA, which is really a complex cardiac anomaly, but it's unfortunately it's a rare, making less than 1% of all congenital heart diseases. As you can see here, it can be associated with dextrocardia. Usually the aorta is anterior and to the right, to the left, and the pulmonary artery is posterior and to the right. And most of the time, the pulmonary artery is much larger than the aorta. In terms of physiology, as you all know, the right atrium is connected to the left ventricle through a mitral valve, and the ventricle is connected to the pulmonary artery. So the unoxygenated blood would end up in the pulmonary artery to be oxygenated, and the oxygenated blood ends up in the aorta. So the patient is physiologically corrected where the and has normal oxygen saturation. There are certain features that make the anomaly challenging, mostly the atrioventricular valve abnormalities. Mitral valve, which is on the what we call in the subpulmonic ventricle, is usually normal, but occasionally may have a cleft and may have some regurgitation. But more often, we see tricuspid valve abnormalities, and the tricuspid valve here being a systemic AV valve has a great importance in being normal or non-normal. The tricuspid valve can be dysplastic and sometimes can have a Epstein type anomaly, which also can lead to tricuspid valve regurgitation. In association also with ventricular septal defect, there may be a major atrioventricular valve straddling or overlying, and the presence of atrioventricular valve leaflet tissue on both sides of the ventricular septal defect may have implications on how to deal with the situation and close the VSD. The VSD can be remote or non-committed or multiple. And also another complicating feature is the presence of left ventricular outflow tract obstruction, which can be present in more than 50% of cases, and it can also be multi-level. We also have problems with the conduction system. The conduction pathways are abnormally situated, and therefore there is tendency to have congenital heart block, which we can see in almost 30% of the patients. And actually, heart block may develop with growth of the patient at about 2% per year. And there could be other conduction disturbances. Coronary circulation, coronaries are normal in general, but they are basically mirror image of what we see with normal hearts. If you look at the natural history of the disease, the crux of the problem is the fact that the right ventricle is the systemic ventricle. So the ability of the morphologic right ventricle and the tricuspid valve being a systemic valve to provide lifelong support of the systemic circulation is uncertain, even if associated with, not associated with any lesion, or the lesions are mild. If you look here at this time frame, you can see this is looking at the patients from birth to death. The risk of atrioventricular block is there from birth to end. Then the tricuspid valve regurgitation can be progressive. If born with a normal tricuspid valve initially, there is still a risk of developing tricuspid valve regurgitation. Then we have arrhythmias, congestive heart failure, and as time goes by, there is an increased mortality risk as well. Now, what is the management strategy? There are many options are available, depending, of course, on the associated lesions and age at presentation. And usually it is the associated lesions that dictate when to intervene and also the type of intervention. Presence of a ventricular septal defect, tricuspid valve regurgitation, pulmonary stenosis, or combinations of these. In certain subset of patients, maybe no intervention or watchful waiting, plus minus medical therapy is warranted, and this is mostly in patients with no additional defects. Then in a group of patients, we repair them, what we call physiologic repair, keeping the right ventricle as the systemic ventricle. We address the associated defects and leave the RV and the tricuspid valve on the systemic side of the circulation. And this option, we have experience with it in more than 50 years. The other option is the anatomic repair, and this restores the right ventricle and the LV and their valves to the pulmonary and systemic circulations respectively. And this approach was introduced in the late 1980s. And then we have the single ventricle or the Fontan pathway, because in a subset of patients with complex anatomy, for example, a remote ventricular septal defect impeding efficient septation, a biventricular repair may not be feasible, and hence we have to go through a univentricular approach. Look first at the physiologic repair, where the RV remains as the systemic ventricle. Most of these patients would have a ventricular septal defect, which can be closed successfully in infancy. However, we have the option of having an initial pulmonary artery banding, then VSD closure at an older age, and at the same time do tricuspid valve repair if needed. In patients who have significant tricuspid valve regurgitation, we have many options. We can do 1.5 ventricle repair to unload the right ventricle and reduce the tricuspid valve regurgitation. We also may add to that some tricuspid valve repair. We also have the option of repairing or replacing the tricuspid valve. And we also have the option of banding the pulmonary artery, so we can stent the septum and reduce the tricuspid valve regurgitation. And this approach of pulmonary artery banding will have the advantage to retrain the left ventricle. We have here, just as an example, a patient you can see with severe tricuspid valve regurgitation, banded, and the regurgitation became much less. And actually, this was maintained for a few years. And some of those patients would actually give you a dilemma where you band them and the tricuspid valve regurgitation improved, ventricular function is preserved, and you kind of wonder whether you should intervene and go ahead and do a full repair that is double switch, or leave them with the band and the RV as the systemic ventricle. Then we have the patients with VSD and pulmonary stenosis. We have the option of closure of the VSD with relief of the pulmonary stenosis, or VSD closure with a left ventricle to pulmonary artery conduit, or VSD closure with the left ventricle to pulmonary artery conduit, and the addition of a bidirectional Glenn, again to unload the RV and improve the TR. All these options would maintain the patient in physiologic repair group. In the anatomic group repair, we'll have to switch the atria. So the pulmonary venous drainage would go to the left atrium, and at the same time do the arterial switch at the outflow tracts. So the oxygenated blood now goes through the left ventricle and into the aorta, and the non-oxygenated blood goes to the right ventricle and into the pulmonary artery. So we'll have to do a Senning or mustard, that's the atrial switch part, plus the arterial switch. Again, we have the option of doing this in stenosis, where we can do this combined with a Rastelli. We also have the option of doing 1.5 ventricle if there is which actually maybe make the procedure a little bit simpler, which hemi-mustard or bidirectional Glenn plus arterial switch or Rastelli. And in some patients, and actually in our experience, we have not seen that, but some can be repaired with the modified Nakaido or the aortic root translocation with arterial switch. Other surgeries that may be needed is the, of course, pacing for heart block, and as I mentioned, Fontan for non-septatable hearts, and resynchronization therapy for impaired function, and if all fails, maybe cardiac transplantation. Dilemma is always for infants born with ccTGA and no additional defects, and the general tendency in those patients is to observe. However, and the reason for that is the fact that the double switch operation is high-risk procedure, such it may be ethically difficult to offer for asymptomatic patients. However, it was suggested that prophylactic early pulmonary artery banding for those patients may allow you to watch the patients and at the same time prepare the left ventricle should a double switch be required in the future. And this is, some of the centers actually are using this as a strategy towards infants born with ccTGA with no additional defects. Looking at the LV training, with the presumption that the anatomic repair is the best option, LV retraining by pulmonary artery banding was introduced in those patients with low LV pressure and LV mass. This same approach was used also in TGA, normal TGA. After a period of time, which can be very variable, the left ventricle becomes prepared to take on the systemic circulation, and then one can do the double switch procedure. We know that the younger the patient, the better chance of adequate retraining. In older children and adults, the success is less predictable and can be associated with a high early and late mortality. Hence, this strategy is not recommended for patients older than 15 years of age. Now, if you look at the difference between the physiological and the anatomic repair, early mortality is variable, but is very comparable. Overall survival is less in the physiological repair. Recurrence of tricuspid valve repair is very high in the physiologic repair. On the anatomic side, the tricuspid valve becomes again on the subpulmonary position, and it's not as important the amount of tricuspid valve regurgitation. If we replace the tricuspid valve on the physiologic repair, that carries a 10% early mortality, and also the reduced 10-year survival, and also the incidence of heart block is significantly high. In the anatomic repair, we still have a superior results if there is tricuspid valve regurgitation compared to the physiologic repair. And if the early survival is good, then there is a 94% chance of patients being in a good functional class for quite some time. In general, anatomic repair is the preferred approach for patients with good mitral valve function, balanced ventricles, acceptable heart, and reasonable coronary anatomy. Poor RV function or tricuspid valve function are compelling reasons to choose anatomic repair over physiologic repair. Hospital mortality for the double switch is high in general, but it ranged in the literature from 0 to 18%. But anatomic repairs have important surgeon-specific and institutional learning. This is from Germany, reporting almost zero mortality in the double switch. However, this presentation was done at the AATS from Toronto Sick Kids, actually kind of making a caveat towards the double switch procedure, making it not the panacea for ccTGA. Biventricular repair at any cost, therefore, is probably not the answer for ccTGA, and despite the familiar long-term Fontan issues, that approach may be favored for ccTGA with complex anatomy. I just have 1 minute. Obviously, there will be many patients that will be in the gray zone who present the greatest dilemma. However, we know that most patients with ccTGA having a Fontan approach have been unsuitable for biventricular repair. And of course, this has always been a question whether a difficult biventricular repair is more superior than the Fontan circulation, but I guess that we can never answer that question. Because if you look here at comparing the three approaches towards ccTGA, you can see that probably if by just a superficial look that the Fontan probably would be the better approach. However, every approach of these has pros and cons, and one has to be really very careful in choosing what is best for the patient. A complex algorithm to how look at it, but I guess it's too difficult, too complicated to explain for now. But this is quite a good algorithm that guides you towards the approach to various subsets of ccTGA with associated malformations. Thank you.